Well, I'm very excited to welcome everyone to this evening's keynote lecture series. We have a very special and topical presenter today, and also UVA alum, Professor David Kallmes, who's a professor of radiology at the Mayo Clinic in Rochester, Minnesota. And if you don't know, he is a former UVA Interventional Neuroradiology fellow and faculty person. He has published and this is an extremely hot topic, which is gadolinium deposition. Patients want to know this more than we realize. We're patients too, physicians, providers, etc. So with this, we can't thank you enough, Professor Kallmes, for coming to speak to us and our world audience as well tonight. Welcome.
Thank you, Dr. Haskell, and thank you for the opportunity to speak with everybody tonight. Is my screen being shared appropriately?
Yeah.
Yes.
All right. Well, thanks for joining. I couldn't help but notice Lee Jensen and John Mugler and Julie Matsumoto and maybe Chris Kramer on the line thinking, what is Dave Kallmes doing talking about gadolinium? He doesn't know anything about MRI, which is true. I'll tell you how I ended up doing this in a minute. I want to give a very prominent shout out, though, to my many-time co-author, Bob McDonald, who figures prominently throughout this talk. So a brief outline. I'm going to try to answer as many questions as I can. They're not all answerable at this time, but first of all, does gadolinium accumulate in the CNS? Spoiler alert, yes. Which among the many agents accumulates? Spoiler alert, all. How does it get there? I think we have a pretty good idea of how it gets there. What form is the gadolinium within these deposits? Are there clinical manifestations? And maybe most importantly for our discussion is, what are the regulatory and legal implications of the deposition, and what does it mean for our patients? So GAD is one of the most frequently prescribed medications in the world. If GAD deposition is an issue, it is a public health concern. Over 400 million doses of GAD have been given worldwide to date. And I remember when I was a fellow during my 3-year fellowship at UVA. Does anyone do 3-year fellowships anymore? I learned that T1 hyperintensity was common in patients with multiple sclerosis and radiation, and it was typically in the dentate nucleus and basal ganglia, and then we just kind of wave our hands and say, oh yeah, it just deposits there. And then I was deputy editor for radiology, for neuroradiology for 8 years under Herb Kressel. And in 2014, this paper came across my desk from Japan, the Kanda paper that's now world famous. And this might be apocryphal, but I'm told that Dr. Kanda was a resident when this was published. So if there are any residents on the line, you can do great things even as a resident. And he did a very simple experiment showing that the change in T1 hyperintensity, and he looked at the ratio of dentate to pons T1 hyperintensity over time. It correlated quite closely to the number of linear gadolinium agent infusions, and concluded fairly confidently that the T1 hyperintensity we see in chronic diseases may well be gadolinium. This paper is one of the most highly cited papers since 2014 in radiology, with 635 citations. So immediately after seeing that paper, I went to Bob McDonald, and he and I had previously collaborated on a big data project when he was a medical student, and I think we hopefully disproved contrast nephropathy, or I should say post-contrast acute kidney injury, looking at 1 million CT scans, and I knew he could do great things. I said, Bob, let's look at a whole bunch of MRIs. He said, no, I don't want to do that. Anybody can do that. I want to find tissue and do mass spec and prove it's gadolinium. So Bob knows everybody across campus. He identified 23 patients, 13 who had been exposed to at least 4 doses of gadodiamide Omniscan. And then with Mark Gentoff from pathology, just painstakingly went through and took small bits of tissue from the dentate nucleus, the thalamus, et cetera, et cetera. Now, the top row here are the imaging findings, and people have shown over and over again, there's a linear correlation between the change in pre-contrast T1 signal and the number of doses you've gotten. But what Bob showed compellingly with ICP mass spec was that in these same areas, there's a linear correlation in the quantification of deposited gadolinium in these same tissues, proving that at least some of the signal is from deposited gadolinium. And a little bit of a shout out to Bob. This paper is actually more highly cited than the Candida paper at 724 citations. Not as high as Dr. Jensen's vertebroplasty paper, but we're coming for you, Lee. It won't be long. I also noted that the second most frequently cited paper in radiology is a COVID paper from this year. Unbelievable. So what else did Bob do? He didn't stop there. Finding gadolinium is difficult on histologic sections. So he did transmissionless electron microscopy and light microscopy and mass spec, and demonstrated that the dark spots you see here are definitely gadolinium. They're almost always around the capillaries and venules. They're perivascular, although about a third of the deposits are in the brain parenchyma itself. So it tends to be perivascular, but it does leach out into the brain parenchyma. Importantly, we didn't find any concerning light microscopic abnormalities in these patients exposed to gadolinium. He didn't stop there. He then looked at every tissue, and it was amazing. No matter the capillary bed, you know, the brain is supposed to be an intact blood-brain barrier should keep it safe from small molecules. Well, neural tissues, privileged sites such as the gonads, cardiothoracic tissues, it didn't matter. Fenestrated, non-fenestrated, every bed had deposited gadolinium using mass spec in these autopsy specimens. Now, this is kind of reinventing the wheel. You can find papers back to the 1980s. And Mike Tweedle is probably the world's expert in this. Everybody's known for a long time that some GAD gets retained after infusion. It doesn't all go away. So this shouldn't have been a complete surprise to us, but it seems like it was. So linear versus macrocyclic. I never learned this stuff when I was a resident or well enough. But there are huge differences in the chemistry and the stability and in the deposition, actually, between linear and macrocyclic GAD agents. The linears have a much weaker GAD chelate binding than the macrocyclics. They are much more likely to spend time in the dissociated state. So you might wonder, does this impact the degree of deposition across agents? So the chemical classification, just very briefly, I'll be using both trade names and other names tonight, but anyway, there is a huge difference in chemical stability where the macrocyclics, Prohance, Gadavis, et cetera, are much more stable than linear ionics, Magnavis, et cetera, which are much more stable than the linear ionics that are much more stable than linear non-ionics. So chemical classification makes a huge difference in terms of stability. Just a couple of words about NSF, because people might be thinking about that. A lot was learned with NSF, which doesn't really exist as a disease anymore because we identified the risk factor, which is renal impairment. But the FDA and the ACR demonstrated different classes of risk factors with NSF, and it gets right to the chemical stability where the linear agents have a much higher risk of NSF than the macrocyclics, and that has actually borne out in the current state of GAD deposition. But I want to be very clear. Almost all of the work done to date, both preclinical and retrospective clinical, has been in the setting of normal renal function. You do not need to have diminished renal function to see deposition of GAD in all tissues. So most people use T1 hyperintensity as the sine qua non of GAD deposition. I will talk to why that's not a great idea, but there is consensus across all the frequently used linear agents. Every single paper showed the same correlation that Candida showed initially in 2014, Omniscan, Magnavis, Multihance, et cetera. Every paper that's been written so far has found a strong correlation between signal intensity and number of doses. Now, the way people measure this is often ratios of dentate to pons, dentate to middle cerebral peduncle, et cetera, et cetera. That's not a great way to do it. I'll talk about that later, but that's the state of the art presently. Conversely, almost every paper looking at the deposition or the T1 signal changes with macrocyclic GAD agents has not shown a correlation. That one paper Stojanov from 2016, there were a bunch of letters to the editor. People were really unhappy about it. It's controversial to say the least. But bottom line is that the lion's share of data is that T1 shortening occurs with linears and not with macrocyclics. There is one paper from 2017 with gadobutrol, Gadovist, a macrocyclic agent, and you have to window and level kind of carefully to show a difference. But they noted 2 patients with, I believe, 34 and 45 doses, 2 patients out of several dozen, where they did see changes in the ratio of dentate to pons signal intensity on pre-contrast T1 weighted images. So yeah, there is deposition even on T1 weighted imaging with macrocyclics. It's just really subtle. What about washout? Well, there's not a lot of data here, but there is some evidence that if you switch from a linear agent to a macrocyclic agent, you might actually see washout. So Rao et al., where they were originally using gadopentate, a linear agent exclusively, Magnavist, they switched to gadobutrol, Gadovist, and for the dentate nucleus to MCP ratio, they actually saw a decrease in signal intensity over time. The globus pallidus to cerebral white matter showed a stability, no further change, suggesting at least for the dentate, maybe there's some washout, and for the globus pallidus, at least stability. Another paper looking at gadopentate, Magnavist, a linear agent, showed really interesting findings. If you look at the dentate, again, it kind of is similar to the Rao paper, the signal intensity increases at 12 and 24 months, but then at long-term follow-up, it goes back down to what it was pre-contrast. So it seems that at least in the dentate nucleus, there is washout. However, in other regions such as the globus pallidus, this linear agent does not show washout. And again, we're saying that there's a tautology between signal intensity ratios and GAD deposition, which is not true. So what are the myriad of shortcomings with T1 signal analysis? Well, there are many forms of GAD that are invisible to MRI, GAD phosphate, GAD, et cetera. Probably most forms of GAD are invisible to MRI. The residents know that you only see T1 shortening when you have a tumbling frequency of your GAD on a macromolecule. If it's not tumbling at the right frequency, it's invisible. Secondly, safe chelated forms are the ones that might be most visible and shorten T1. So we can't see most forms. The ones we can see might be the safest. There's complete lack of standardization of how T1 weighted sequences are analyzed, imaged, compared across studies, institutions, vendors. These ratios we talk about are imperfect. There's not been a lot of quantitative T1 mapping in this space, which I find surprising. It's a T1 signal changes are very qualitative. Quantitative tissue assays are, I think, the only way to go to know for sure. So Bob, after publishing that paper in radiology looking at cadavers, I then opened my lab to him and said, let's do some rat studies. Now, these rat models are really imperfect. Back in this, I think, 2016, we did this. The models were giving a whole lot of GAD over a short period of time, 2.5 millimoles per kilogram, massive doses daily, 5 times a week for a month. These are huge, super clinical doses. We looked at both linear and macrocyclic agents, ProHance, Gadovist, Multihance, and OmniScan. The latter 2 are linear agents, the former 2 are macrocyclic. And then, like with the autopsy study, did mass spec and histology. And what did we find? Well, and here's it took us a while. I have an amazing pathologist in my lab. She is a genius, but it took her quite some time to figure out how to get a nice coronal image of the dentate nucleus in a rat. In the upper left here, you can see that little red triangle there. And if you look at the T1 weighted pre-contrast imaging, all of the agents in the very tiny dentate nucleus demonstrate T1 shortening. It's not just the linear agents. If you look at the percent signal change from baseline, it is worse with the linears, but it happens in all. Most importantly, looking at the concentration of GAD in these various tissues, we see that all agents accumulate. The linears more than the macrocyclics, but all of them accumulate. ProHance is the least. Bob then looked at all the tissues again, and the scale here is you have to really blow up the brain. so the brain levels don't even show up when you use the same scale as the other organs. But again, you see deposition in the brain. You see most deposition in the kidney. You also see it in the liver and the spleen. Interestingly, the ProHance had the least deposition, but as I'll say later, it was the only one that showed histologic changes in the kidney. Nothing else showed any histologic changes in any organ. Now this, and there have been a lot of rat studies. I could only find a single large animal model. And this was from Radbrook, who's written a ton about macrocyclics and the safety of macrocyclics. When I first read this paper, I said, why did he just do a single injection of a clinical dose? So he looked at multiple, he looked at linears and macrocyclics, and did histology 10 weeks after a single infusion of a clinical dose of gadolinium. And you can see that only the linear agents accumulated, the Omniscan and the Multihance. None of the macrocyclic agents had any demonstrable gadolinium. And I actually think this was actually a pretty smart study because this does mimic the clinic, and the sheep is a reasonable large animal. And you know, I guess we can say that after a single dose, you're not getting much deposition with the macrocyclic. You're getting some with the linear. So I think it's actually a pretty good study. I would like to see more of these studies in the future to confirm the results. Now, we know that linears we know from autopsy data that linear agents accumulate. There's really scant data on macrocyclic agents in autopsy studies. This is a fairly early study from University of Washington, where they had 9 patients who had autopsies, and they quantified using ICP mass spec in the usual areas. And that first patient was administered Gadovist just 5 days before death. There's that second patient who did have fairly high levels of GAD deposition, but it's only a single patient with Gadovist. There's some ProHance data here with much lower deposition. Kanda actually published a paper with a little bit of ProHance data. So there's it's basically case reports. There's a little bit of deposition, even in autopsy studies with macrocyclics, but not nearly as much as with linears. So this is really important. What is the chemical form? I'm not a chemist. I don't know a lot about gadolinium chemistry, but I found this study to be pretty reassuring. It was a rat study again, the usual high dose supraclinical doses, and they actually tried to speciate what the gadolinium was retained in. They had both an insoluble and a soluble component. And the macrocyclic agents, you can see, were not in the insoluble fraction at all. So if you look at the upper graph, to the left are the macrocyclic agents, to the right are the linear agents. On the bottom, the macrocyclic agents and the linear agents at 3 days and a longer time point have pretty similar deposition in the soluble fraction. It's interesting that the molecules that they felt that the macrocyclic agents were in were soluble molecules, not macromolecules, and wouldn't be expected to shorten T1. So I think we can say that just because you don't see T1 shortening, it doesn't mean there's no GAD there. Conversely, the linear agents were predominantly in insoluble molecules, which probably are biologically inert. They were also in soluble molecules, but also very importantly, they were found in soluble macromolecules, which explains their imaging and T1 shortening. So it's a really complicated thing, but I think we have some reason, not only certainly differential deposition, but also different chemical forms that speak to potential safety, as well as what we're seeing on image. So I would say that using the surrogate marker of T1 shortening is going to be more sensitive to linear than macrocyclic agents, and can't be the only way that we compare these GAD compounds. So where are we? This is a few years old, but things haven't changed that much. On top there are the linear agents, and there's lots of signal intensity changes. There's almost no signal intensity data for the macrocyclics, except for that disputed Stojanov paper. In terms of quantitative T1 changes, there's just a couple of papers, not much out there. And in terms of gadolinium deposition, as I said, Bob's paper is the biggest one. Kanda and Murata have a tiny bit of macrocyclic data, but they found agents in all patients that were administered these compounds. But I will say I am not aware of any histologic abnormalities to date in the CNS after GAD deposition. So how does GAD get there? You know, the brain's supposed to be protected, right? The blood-brain barrier. Well, we know that there are certain normal features in the brain that enhance. I'm embarrassed to talk about this in front of Julia Matsumoto, but anyway, the choroid plexus, we know that that's permeable to small molecules, so it makes perfect sense that it enhances after gadolinium infusion, so why wouldn't it leak out of there into the CSF? And there is some thought about the lymphatic system, which I know very little about, but there are some papers suggesting that the lymphatic system has a role in how the gadolinium gets shepherded through the brain and ultimately deposited. This is very early work. People don't know a lot about it. So Bob McDonald's wife, Jennifer, has been in my lab for many years, and she did a study, a clinical study. It was kind of a convenient study where we found patients who were going to get a clinical workup that required a contrast-enhanced MR and an LP. And we tried to make sure that the LP was done after the MR. This is just a consecutive series of patients who were going to get an LP and an MR, and we looked at whether or not Gadovist was found in the CSF. And lo and behold, it is. It doesn't really depend on whether or not you have a normal scan. So patients, even the lower right here, people with a normal exam and normal CSF protein had gadolinium accumulation in the CSF after infusion. Having abnormal CSF protein was the strongest predictor of having GAD there. It was a little bit different between adults and children, fortunately, although it does deposit in children. That's been shown with histology from a paper that Jennifer published in JAMA Pediatrics. But we found with this study that absolutely early on, there is gadolinium getting into the CSF, likely through the cord plexus, and it's measurable to up to 200 hours after GAD infusion. This doesn't explain how it gets into the parenchyma, but at least we know how it's getting past the blood-brain barrier. Now, are GAD deposits toxic? We know they are, right? We know from NSF that they're toxic. And Mike Tweedle has a hypothesis that it's transmethylation, where iron and other charged particles kick out the gadolinium. The gadolinium somehow activates fibroblasts and fibrocytes, and those explain the terrible clinical manifestations of NSF. We don't have the same signal yet. There's a small paper I'll talk about in a minute about cytokines, but we really don't have any data that this is active in CNS GAD deposition. There are other nephrotoxicities, hepatobiliary toxicities, pancreatitis that have been shown in case reports, but we don't know that the GAD that's depositing in the brain is toxic. I mentioned earlier that in the preclinical studies that Bob and I had done, we didn't find any evidence of abnormality histologically, except in number H here and letter H here. This is a ProHance rat that had really profound vacuolization of the mitochondria in the proximal convoluted tubules. It wasn't seen in any other samples. I'm not sure what it means. So moving on, are GAD deposits clinically relevant? Well, I think we should think about structure and function to see what symptoms we should be looking for. And certainly the highlight deposition areas are the dentate nucleus and the basal ganglia. So obviously, dentate nucleus, you're going to look at coordination of limb movement. In the basal ganglia, look at learning and memory, coordination of movement, as well as anxiety and mood disorders. And so the preclinical and clinical studies that I'm going to talk about in detail in a minute are kind of informed by this approach. What data do we have to assess potential clinical toxicity? There's not much. We have preclinical studies that are not necessarily definitive. The clinical data, we have our retrospective reviews of convenience samples and a little bit of prospective fMRI data I'll talk about briefly. So this is a paper that just came out in Radiology that I thought was really good. It's the first time a preclinical study has moved beyond the brain to look at the spinal cord and peripheral nerves. And they looked at two agents, gadodiamide, OmniScan, a linear agent, gadoterate, a macrocyclic agent. They looked at two doses. Again, these are huge doses, superclinical doses. And they looked at baseline, day 7 and day 14. And they were trying to identify clinically meaningful changes in these subjects. And in terms of peripheral nerve damage, they have some provocative data here. If you look at the top graph there, that's heat hyperalgesia. And the bottom red line there is the high dose of the linear agent. And the latency for moving a paw away from heat is pretty short, means they're pretty sensitized to pain. And and B there is withdrawal frequency after stimulation. Again, you're just seeing a signal from the high dose linear agent that maybe there's something going on with pain sensitization. They also looked at memory, working memory, and they looked at hippocampal cellular proliferation and neurogenesis, and saw no differences across agents in those outcomes. But again, a provocative study suggesting maybe some clinical manifestations from high-dose GAD infusion. Bob and our team moved forward into this area as well, using the Mayo Clinic Rodent Behavioral Core Facility and looking at many different agents, linear and macrocyclic, using multiple behavioral tests, including open field arena, Y-maze, and others I will talk about in a minute. In addition, we did mass spectroscopy and light microscopy. So just these are unpublished data, and they're incomplete, but what we know so far is we're not seeing a strong signal. Now, we looked at both linear and macrocyclic agents, and we looked at 2 different doses, 80 human equivalent doses and 20 human equivalent doses, just because there was some thought that if we are seeing renal toxicity, as we saw earlier, maybe that's going to change behavior. So using a test of spatial short-term working memory, this Y-maze, we saw no difference across agents and across dose in terms of percent alternation, which is an indirect measure of short-term working memory. Working memory and potentially anxiety are tested in the open field arena. And again, across doses and across agents, we saw no difference in this test of working memory and anxiety. And lastly, a test of social anxiety. This is done with a stranger rat present and alone, looking at percent time in a stranger zone. We did see differences, significant differences, whether or not a stranger rat was present, but whether or not a stranger rat was present was, there were no differences in the high dose or across agents for the social anxiety. So using the rodent behavior facility here, we have not been able to identify any quote clinical manifestations of gadolinium deposition, and these subjects were proven to have gadolinium deposition on mass spec. What about clinical data? There's not much. There's a paper from Canada that came out a few years ago, again, a convenience sample, where they happen to have administrative data on a large number of patients, and then data on whether or not they develop Parkinson's. Now, I know Parkinson's is not the first thing you think about with GAD deposition, but it was the data they had. It was a large number of patients, about 100,000 patients who had been infused gadolinium. And in the adjusted analysis, they saw no association between infused gadolinium and patients developing Parkinson's. So not the best study, but at least it was negative. Bob has done a great deal of work here in Rochester with the Rochester Epidemiological Project, which is world famous. It's the longest and largest community-funded NIH study of human health. There's a sub-study with Ron Peterson, the world famous Alzheimer's researcher for the past 15 years. It's a prospective population-based cohort to study prevalence, incidence, and risk factors for dementia. And wouldn't you know, patients had been sometimes infused gadolinium for over 10 years. And like the Rochester Epidemiology Project, it's prospective, and they also do detailed neurological, neurocognitive, and neuropsychiatric functioning. So this is just a treasure trove of potential data to look for associations between dysfunction and GAD deposition. So briefly, patients are enrolled when they're cognitively normal. They undergo MRI, which may or may not be contrast enhanced, and they're followed longitudinally with imaging, with lab exams, and with detailed clinical, neurological, and neuropsychological evaluation. So Bob pulled the data, and over 8 years was able to find over 4,000 patients who'd undergone cognitive assessment, about a third of those patients had been exposed to the linear agent OmniScan. And amazingly, almost half of that cohort had 5 or more doses. They were followed for 5 years. So looking at the unexposed and the GAD-exposed patients, they were pretty well matched at baseline in terms of age, other risk factors, Charleston Index, and the neuropsychological exams at baseline. And comparing groups, those exposed to gadolinium and unexposed, found no difference in mini mental status exam or any other memory, language, attention, or other neuropsychological examinations. So there's no signal here that getting gadolinium is dangerous in terms of neuropsychological and neurological outcomes. No association was seen from the Rochester epidemiological project. Then looked at a Kaplan-Meier model to see if there was a difference in rate of converting to cognitive impairment over time. And just like with the clinical exams, there was no difference between groups in the rate of conversion to cognitive impairment, whether or not the patients had been infused gadolinium. So again, no signal here to suggest that GAD is toxic neurologically. More work needs to be done. So here's a summary, a recent summary showing all the clinical papers. And again, there aren't many. They are both papers with linear agents and macrocyclic agents. Some of them are with multiple sclerosis. Some of them are other disease entities, but none of them has shown worrisome clinical changes in patients exposed or not exposed to gadolinium agents. Now, there's 2 relatively recent papers that are prospective. They both looked at quiescent Crohn's disease. So the first one had 16 patients with quiescent Crohn's and demonstrated T1 hyperintensity in the dentate nucleus, but they were unable, using resting state exams, quote, Crohn's patients with GAD-dependent hyperintensity in the dentate did not show dentate nucleus resting state functional connectivity changes. So a negative, very small study. Conversely, using a different technique in a similar study population, 14 patients with quiescent Crohn's and documented T1 hyperintensity, they did see significantly decreased resting state functional connectivity in the right frontoparietal and dorsal attention resting state nuclei, network. So the prospective clinical data is scant, but maybe there's a signal there. Much more work needs to be done. So what about gadolinium deposition disease? This is a disease that was first reported by Dr. Semelka. There's not much data on this. The original paper was 17 patients with self-reported symptoms, and the 5 symptoms are peripheral neuropathic pain in a glove and stocking pattern, joint stiffness, muscle spasms, headache, clouded mentation, and distal extremity and skin substrate thickening. So it's a constellation of findings. I'm not sure it quite should be raised to the level of a disease. I would say it's more accurately a gadolinium deposition syndrome, more a collection of signs and symptoms that are associated with a specific cause. Unfortunately, GDD is now in the medical and medical legal literature. I don't think we're going to get it out. There's not a lot done with this yet. Dr. Semelka did do a prospective study looking at cytokines in patients who have noted GDD. So a couple of dozen patients compared to patients who didn't have gadolinium exposure. They did have some hypotheses about cytokines that might have been pro-fibrotic and other cytokines that would be potentially causative of the symptoms that I listed a minute ago for GDD. The reasons for the MI were myriad. There's no specific patient population. And again, the agents were both linear and macrocyclic. And so what did they find? Well, they did find that serum levels of 14 cytokines, including 9 pro-inflammatory cytokines, were statistically significantly elevated compared to controls. Now, again, the controls are healthy controls. I believe they were getting vaccinated. However, the hypotheses regarding pro-fibrotic cytokines to specific symptom intensity were not confirmed. In any event, these authors conclude that individuals developing symptoms characteristic of GDD should be studied to investigate whether gadolinium retention and elevated cytokines may be related to their symptoms. I think that we don't know yet. The jury is out, although that might be a bad analogy to mention. Speaking of juries, where's John Smith when you need him? This is from the Journal of the American College of Radiology, written by MD JDs, and they talk about a looming risk management threat. This is early days, but they note in the wake of NSF, personal injury lawyers are no stranger to GAD-based lawsuits, and that GAD deposition disease, although unproven, has nonetheless stimulated impressive regulatory and industry response. They, from their medical legal background, do not recommend specific informed consent about deposition of gadolinium at this time. They suggest perhaps shared decision-making should be the way to go. Then they go really far out and say that we should be using ProHance over all other agents based on animal studies and expert opinion. I don't think we're quite there yet. Now, pivoting a little bit. We've been talking only about chronic safety. We haven't said a word about acute reactions. And if you're a patient, the acute reaction might be the most important thing to you. And there's pretty good evidence from a lot of papers that probably linear agents have lower acute reactions as compared to macrocyclics. And within classes and within protein bindings, it also affects rates of acute contrast reactions. This is something that nobody's really talked about. And this came to the fore at a major medical center in the Midwest after this medical center switched from gadodiamide to a macrocyclic agent, Gadovist, and two patients who had previously been imaged with linear agents presented as outpatients for GAD-enhanced MR, and within 10 and 40 minutes, both patients suffered acute dyspnea. The residents may notice the patient on the top has dextrocardia, which is not relevant, but both of them developed dyspnea requiring ECMO, and these were almost certainly related to the gadolinium infusion. So I don't think we should just be talking about chronic risk. We should be talking about both chronic and acute risk, and maybe that should be part of the equation. Well, regulatory. Everybody knows that in 2017, the Europeans decided to get rid of, almost get rid of linear agents, Omniscan, Magnevis, and Optimark. They still allow multi-hands imaging for liver, but otherwise they only, they're maintaining all of the macrocyclics, Dotarum, Gadovist, ProHance, etc. So they have acted, and in Europe, it's all macrocyclics. The FDA has been much more cautious. They've had several announcements, 3 altogether, one in 2015 and 2 in 2017, and quote, they are investigating the risk of brain deposits. It's unknown whether these deposits are harmful. Healthcare professionals should consider limiting gadolinium. I'm not sure how helpful this is when necessary, and the available information does not identify any adverse health effects. They then, later in 2017, said, although GAD retention has not been directly linked to adverse effects, they are going to have some changes. They're going to require changes to the warnings and precautions. And then this new patient medication guide, quote, that every patient will be asked to read before receiving a GAD agent, and requiring manufacturers of GAD agents to conduct human and animal studies to further assess the safety of these contrast agents. So I went and pulled, this is section 5.3 from that patient guide. This is, I mean, when you go to get an MRI, you're not thinking about this stuff, right? This is a lot of information to swallow all at once. I'm not sure how helpful this is. It's a lot of information. They say gadolinium is retained for months or years. The consequences of gadolinium retention in the brain have not been established. While clinical consequences of retention have not been established with normal renal function, certain patients might be at higher risk. I don't know if your patients are reading this, and even if they were, I'm not sure that they're learning very much. So in summary, it is clear that all agents, including macrocyclics, deposit in the brain and other tissues. Macrocyclic agents deposit less. There is, as far as I know, no histologic evidence of neurotoxicity. There's no threshold of toxicity from GAD administration. There's only early preclinical studies and one fMRI study that has any clear potential harm. Linear agents have a more favorable pharmacovigilance risk profile, have a lower rate of adverse events, and maybe we should factor that into the equation. There's a lot more research that needs to be done in terms of the clinical effects of GAD exposure and GAD deposition, the mechanisms of uptake, clearance, and dechelation. Before I finish, I want to give a shout out to our huge multidisciplinary team. I can't name everybody, but certainly Bob and Jennifer leading the preclinical and clinical studies, and Mark Gentoff in pathology, going through all those original histologic samples to get us on the map for GAD research. And of course, the people behind the rep and giving us all that clinical data. So with that, I'd like to thank you for your attention.
David, this is what a giant applause sounds like when everybody's muted.
Right.
You can be sure of it. We have people from all over joining us. That was absolutely extraordinary. As an interventional radiologist, I am right now petrified, as a patient as well. We have a number of questions over here. Let me first start with those. Given the data that you've just shared from looking into the clinical implications of GAD storage syndrome, the question is, what do you think should be a strategic direction for MR research right now? Is it to try and veer off, essentially wean from the use of gadolinium? That's the first question. Or larger doses of it, or other agent classes that we're not aware of.
Yeah, and I know that the strategics are looking at this. They're looking at other agents, but I don't know that much has moved. Any heavy metal you put in there is going to potentially be neurotoxic. So I don't see us getting away from gadolinium anytime soon. In terms of the research we need to do, I think speciation is a huge deal. I think if we could speciate what's there, we could understand the risk profile much better. But that's really early work, and I'm told from Bob that Mayo, he says I could mention it tonight, that they are getting a new speciation assay up and running, and so it could be that we have a lot more data soon. But yeah, I think everybody's thinking about manganese and where that's going to take us. Well, that's going to take us potentially to Parkinsonism, right? It's been tried before, and I don't know. Maybe somebody's figured out a way to use manganese safely, but right now I think we're going to have GAD for at least till I retire.
So you've really captured the FDA's position on it thus far, and I think Japan has also gone off of linear as well. I mean, how much more evidence do we actually need, and what are we really going to get in the U.S.? Why haven't we just dropped them at this point? I mean, do you view us as essentially lagging, or what bomb has to drop?
When it comes to regulatory, I don't know what to say. I don't know, it's not necessary. And the Europeans' decision to ban the linears wasn't necessarily rational. It was based on the people in the room who spoke the loudest. So I think if I'm a patient, I likely would be more comfortable with the macrocyclic agent. Certainly for liver imaging, there's a lot of reasons to use linear agents. So I don't think what the Europeans did was wrong. I think the FDA is just more conservative. I don't know what research is going to move the needle, or if anybody's working on something that's going to change the FDA's mind in the near term. There's plenty of data out there already.
I want to encourage people to unmute and ask questions in addition by voice and not text. And until I see more, or anybody, feel free to speak over me.
Zeev,
yes.
Zeev, can I ask a question?
Thank you, Dr. Caldwell from our liver service.
Yeah, thank you very much, David. That was really excellent. I just want to make a couple comments on we've had a fair amount of experience with ultrastructure in liver, looking at mitochondria. And I noticed you mentioned that with the mitochondrial changes, and I can put me on video so you can see who you're talking to. Really old guy. And but the liver and fatty liver especially, it's really hard to interpret that in, looking at EMs and ultrastructural things. It's more fuzzy than even looking at MRs and the things you've been talking about, the questions you've raised. I think it may be significant, but it may not be, and certainly it's going to be a lot of years before we understand that.
And the changes we saw with our preclinical model, that was renal. So the only mitochondrial change we saw was in the kidneys with ProHance. We didn't see any other histologic change in any other agent, any other vascular bed.
Yeah, I caught that, and I think it's really interesting, maybe significant. I know it was only in one patient, specimen H, I think you said, but just beware, those are really hard to interpret, as I'm sure you already know. The other comment I had, and first of all, I should thank you and Zee for putting this together. And I really did note how many radiologists are on here. You know, I thought it would be a bunch of us consumers. So I'm really glad to see that we're not the only ones with a whole bunch of questions about all this. And I really think this has been outstanding. And I know there's at least one other person from hepatology on the guest list, and there's a few. Well, I see two actually.
Steve, as a liver oncologist, or try to imagine yourself speaking for an IRB or for oncologists in general, we're ordering scans every 3 months on people.
Yeah.
Do we think that this should start to get into our own sort of protocol and subconscious and such as well, or?
I totally appreciate it. I don't know how many people in this discussion have ever testified in court. I have, both in defense, one time in plaintiffs. And I can tell you, you're not before a jury of your peers. You're before a jury of kind of whoever they can gather up. And the outcome of such things is a lot dependent on how well the attorneys perform. And I've seen it go both ways. And so I totally get the concern about plaintiffs' attorneys. I mean, that's where, because I thought the data on GD sounded really, really shaky. And, anybody sued over something like that, call me. I'll be glad to participate in the defense. I kind of doubt this is a real concern, but it is something that plaintiffs' attorneys are very talented at making into a real concern, unfortunately.
Let me draw Dr. Matsumoto into this for a couple of questions. First, Alan, do you think that we're going to be asked to have patient diaries for gadolinium doses? Secondly, what are you thinking in terms of service to a leadership, and also in your ACR role, what do you see coming down the pike?
So to question one, patient diaries in terms of gadolinium dose and type of agent, I know a number of patients have asked that. One of the patients we referred up to Dave and Kallmes and the McDonald's for a consult. One of the reasons I got connected with her, she complained that our reports didn't mention the type of gadolinium, used terms like so many millimolars per kilogram. She wanted to know exactly what agent and what volume. So I think that would serve well if we're going to try to be patient-centric to ensure that we have that information, the reports, and they can create their own diaries, whether we do or not. Eventually, it'll probably be easy to develop. In terms of the ACR position, I think they'll go with someone like Dr. Kallmes and ask him to serve on a panel and advise them. It would really flip the world of biomedical imaging on its ear if we did not have contrast agents for so many different disease entities. So I think they're going to be relatively neutral and take that more conservative role, in that there's not enough evidence to do anything about it right now.
How about an even more basic day-to-day level, which is, should you be able to specify as a patient that you want one or other class of agents when you're having your MR?
Yeah, I think that'll be hard. I'll defer to David and ask him how he feels about it. And he and Bob and Jennifer probably get asked this all the time about what they should do at the Mayo. And the Mayo is a much bigger system than the University of Virginia. So what do they ask you, David? And
Yeah,
how you guys...
so Ziv, Bob McDonald has joined the call, and I'd love to hear from him. Can he, you want to unmute, Bob, and give us your perspective on the patients that have been sent from UVA and what you're telling patients?
If you're there, we can't hear you yet.
Yeah, I don't see these unmuting. Yeah, I don't know that we have a united front here. I would certainly never tell a patient that if they request a macrocyclic agent that they shouldn't. Oh, here's Bob. Yeah, go ahead, Bob.
Can you hear me now?
Yes.
Oh, weird. Okay, so even I called in on a phone because my computer does not have a
We have you
microphone.
loud and clear.
Okay, fantastic. So let me rewind here before we talk about that. Just wanted to bring up a few points. So I testified to the FDA, the EMA, when all this was going on, and all of the MIDAC committee, and have actually helped also serve as a consultant with all the ongoing litigation over gadolinium deposition disease. And so my perspective, I'll just give you the 1 minute perspective on what happened, especially between EMA and FDA. So the EMA used something called the precautionary principle. I personally believe, and this is my biased opinion, they abused it because they basically said if there's any potential for harm, we can pull an agent from the market, and that's what they did. You can imagine though how this could be disastrous. Imagine if you started saying, well, people can get sick from aspirin and die from aspirin, and obviously they can. Well, now the EMA's position is that they could arbitrarily pull any agent for any theoretical risk. The FDA, however, has a different standard by which they use whether or not they can restrict use or pull an agent from market altogether, and that's they have to prove evidence of harm. And that's the one thing that even the FDA says has not yet happened, despite claims of GDD and whatnot. In terms of the litigation with GDD, there have been many lawsuits. There was an attempt to consolidate with a class action lawsuit, and in Arizona, they took it to a district court judge where, and all four manufacturers were there, and obviously they have a vested interest in seeing this not happen, and the district court judge was able to very clearly say, I learned a lot that actually some judges are very knowledgeable in science, that there was no evidence of causality, and it's called the Daubert argument. And so the Daubert case failed for the plaintiffs, and in part because the expert witnesses for the plaintiffs were caught going on record at the FDA's MIDAC meeting saying one thing and then testifying that gadolinium is toxic when it serves the purposes of the plaintiffs. And so they got caught because that's all documented. It's a great reminder for all of us. And so the entire case was thrown out. And so most of that litigation, and even I'm sure you guys have seen the Chuck Norris litigation, they have either arbitrarily pulled or cases have been dismissed because really right now GDD is kind of viewed as a disease that was almost fabricated before we could ever prove it existed. And frankly, there are people who are chelating gas out of people's bodies, I think, for monetary gain, not because we know it helps them.
What is the Chuck Norris? What is the Chuck Norris thing? I've never heard of it.
Yeah, so Chuck Norris's wife received one of Bracco's products. Not that that's important, but and she claims she developed symptoms of gadolinium deposition disease. Now, interestingly, she had some of these symptoms before she received the gadolinium. This is the issue with GDD. We're very good at imaging at the inflection point of people's health when all of a sudden their symptoms start becoming a real problem. And so it becomes a difficult conundrum to prove causality. And in her case, they couldn't. And so and this made national news because Chuck Norris started saying, you know, my wife was harmed by gadolinium. So this actually made the national news. And we were worried this was going to put a stake right through the heart of gadolinium, because of course it was spun that this toxic metal is getting put into people. And in terms of,
so let's put aside the medical legal aspects for the unclarity and for all these sort of aspects of causation and proof. But Bob, give us your perspective in addition to David's in terms of where you actually take this and what you think we're at in the U.S. in terms of both recommending to patients or making individual decisions either for ourselves, family, or on an institutional of what we stock and use. Give us our sort of closing thoughts.
So I think what the changes that have occurred that have been pushed by the FDA and even in most institutions, including Mayo, are doing it is certainly, and the market is shifting to class 2 agents, which are the macrocyclic agents and multihance, are now the preferred agents of use. And the reason is that their kinetic lability is such that even if they hang around inside of us for hours to days to even years, they should remain stable as an intact chelate. And so I think, like what the FDA and the NIH and the ACR, all these people are saying is that especially in patients where you expect to image them multiple times over their life, in those patients in particular, we should probably we should use a class 2 agent. And I think that's a reasonable thing to say. Now, that is not to say that we should totally abandon like the class 1 agents, what's left of them, because many of them are being withdrawn voluntarily from the market by the manufacturers, or they're bringing them to China, and we aren't going to have access to them anymore. Because I think, and what Dave nicely showed is that there are good data that the linear agents like Optimark and Omniscan have far more favorable adverse. So their likelihood to cause a hypersensitivity reaction is somewhere on the order of 10 to 50 times less. And so that, and to give in our perspective, we've seen a dramatic rise in adverse events when we changed over to macrocyclic agent versus our linear agent, and which was Omniscan. And so accordingly, I think, and this isn't to say Omniscan is better, it's just so in patients who are either tenuous in the ICU or have had a prior reaction, this should be your first-line agent. That's my perspective, and then,
that's a spectacular summary. We're up at the 9 o'clock hour. I can't thank you enough.
Can I ask one more very practical question?
Ask a quick question to close us out, Steve.
Thanks. I didn't catch everywhere that this gets deposited. Is it in the ponds, and does it influence our diagnosis of CPM? I'm sorry if I missed you commenting about the ponds.
It is in the ponds, not as much as other regions, but I don't think it has anything to do with that diagnosis. But it's everywhere in the brain that we've looked.
Okay, thank you.
So that's our closing message there. It's everywhere in the brain that we've looked. Gentlemen, Professor Kallmes and Professor McDonald, thank you so much for the pioneering work in this and for both of you coming on. That's really a treat for us and for all those who are going to enjoy this recording beyond this evening. Thank you, everybody. Clapping from across the world.
Thanks very much.